Thank you very much, Connor, and thank you for asking me to speak about this. What I'm going to do in the next half hour is say a bit about the acute and chronic effects of locoregional treatment for breast cancer, which of course is primarily surgery and radiotherapy. I'll talk a bit about the implications for the patient and the radiologist, and I'll also say a little bit about the effect of changing treatment paradigms on what we as radiologists are going to see. So breast cancer remains the second most common cause of cancer-related death in women. However, there have been marked improvements in survival over the past 3 decades, and what that means is that for many patients it may be a chronic disease. Furthermore, with the ever-increasing use of cross-sectional imaging, which we're all familiar with, even the general radiologist who is not a breast radiologist needs to be familiar with the spectrum of both normal and abnormal cross-sectional findings. So the mainstay of treatment is surgery and radiotherapy. So surgery may be wide local excision or mastectomy, with or without oncoplastic techniques and immediate reconstruction, and then some form of procedure to stage the axilla, either a sentinel node biopsy or an axillary clearance. Whether or not the patient receives radiotherapy depends on the post-operative histology, particularly the T-stage, and risk factors for local recurrence, such as margins, the prevalence of an extensive intraduct component, so on and so forth. And it may be given to the breast, the chest wall, the axilla, and all the supraclavicular fossa. Now, I'm not going to say too much about chemotherapy because it's really a systemic treatment, but there are 1 or 2 things we do just need to be aware of. So the sequelae of treatment may be acute or chronic, they may be expected, or they may be unusual. And it's important to know about them because many of these normal findings afterwards are symptomatic. And as breast radiologists, we need to know the impact they have on follow-up imaging, primarily mammography, and also what they look like on predominantly CT scans. So dealing first with surgical changes, the most common acute finding is that of a seroma. Infection occasionally occurs, which can go through from cellulitis to frank abscess formation. Hemorrhage is relatively unusual and obviously presents pretty acutely. Fat necrosis in the instances of reconstructions. Skin thickening and edema is very common, and with wide local excision tends to be localized, unlike, for example, radiotherapy, which I'll say a bit more about later. Seromas are typically seen as ovoid masses on mammograms, and if you look 1 month post-operatively, as many as 50% of patients will have them. They do tend to resolve with time, but they may persist, and they tend to be commoner with mastectomy as opposed to breast conservation. On ultrasound, they look like complex cystic masses. They may defy aspiration because of multiple loculations. And requirement for drainage is not uncommon, particularly in the axilla, where it can be quite uncomfortable. Hematomas, as I mentioned, are relatively unusual. And so this is a patient who's had a wide local excision on the left side. You can see the clips there indicating the tumor bed. At least I think you can. And then a year later, you can see that the seroma has persisted, though the post-operative changes diminish generally, but notice the increase in skin and trabecular thickening here, representing radiotherapy effect, about which I will say more. On ultrasound, it's typical to see this sort of appearance with loculated collection. And in the axilla, this is actually post-drainage, but you'll notice, of course, the proximity to the axillary vessel. So if you are going to drain it, you just need to be sure you know exactly where you are. This patient was having a CT for staging when she'd had rather more extensive nodal disease than was anticipated. And you can see that there is a very large seroma in the breast, but also the axilla, and notice also the skin thickening immediately post-operatively. Now, with time, the seroma does diminish in size, as you see. And here is a patient with a persistent seroma post-mastectomy, and you can see it heading off up into the axilla here. If the seroma resolves, particularly in the axilla, it can look very, very mass-like, and that is not to be confused with local recurrence. So here there was no evidence of local recurrence, it was just scarring. Now, these mammograms show the acute effects, and you can see a diffuse increase in density on the operated right side, it's actually quite difficult to work out where the scar is, but when we look a year later, you can see that there has been resolution of many of the generalized post-operative changes, but with condensation and maturation of the scar in the upper outer quadrant of the breast. And if I could find my marker, I would point that out to you. There it is. And notice also the focal skin thickening and retraction. Most likely, if you're looking at CT scans, you are going to see scarring both in the breast and the axilla. And so here's a patient, and you can see at the topmost slice here, there is a little bit of fibrosis. And as we go on down, it really can look quite mass-like. Again, this is quite normal with no evidence of recurrence. Now, I can't really separate out the effect of surgery from that of radiotherapy in the breast because they are so often given together. Whole breast radiotherapy has been standard of care post-breast conservation for many years now. It has survival benefits and it has a dramatic effect on local recurrence rates. Most of these local recurrences tend to be near the tumour bed. And in fact, the risk of developing breast cancer in the ipsilateral breast outside the immediate tumour bed is the same as that of developing a contralateral cancer. Standard radiotherapy is given in 1.8 to 2 Gray fractions daily over 5 to 7 weeks, so it's pretty exhausting for the patients, to a total dose of about 50 or 60 Gray, with or without a boost to the tumour bed in younger women who are at higher risk. Recently, there has been a trend towards hypofractionation, in which a smaller dose is given in slightly bigger fractions, and that has the advantage of patient convenience. These are the typical portals that are used. There is a tangential field outlined here, which treats the breast or the chest wall, a supraclavicular field, and an internal mammary field. And this is what typical radiation therapy planning looks like using CT with conformal radiotherapy. The green here represents the isodose encompassing the supraclavicular fossa, the axilla and the chest wall, and is immediately apparent that clearly some of the lung is going to be irradiated. The major effects that breast imagers see is on the skin of the breast. And this is very well recognized on mammograms. It has a well-defined time course, and the main thing we see is an increase in breast and trabecular thickening. It's usually maximal around 6 months after completion of treatment, but the perceived increase in density, because the breast is less compressible, can persist for some time, as can the edema. So here is a patient who has just been treated. This is the first post-treatment mammogram on the CC views and the oblique views. And you can see the clips indicating the tumour bed here, but the diffuse increase in density and trabecular thickening. And then we go on to look a year later, and you can see now that what has happened is that we have diffuse skin thickening, the trabecular thickening is persisting, and here at the site of the tumour bed, we now have established fat necrosis with typical dystrophic calcifications. On ultrasound, the appearances may be a bit confusing. This is a patient who is fairly immediately post-operative, and she had her tumour resected from the subareolar region. Now, if you look closely, you can see that there do seem to be some oil cysts here. And on ultrasound, we have a little cystic component, lots of hyperechogenicity of the surrounding fat, but at another level it really does look quite solid, and you can be forgiven for thinking that might be solid, and yet if you stick a needle in it you will be able to aspirate saponified fat. And notice also a very, very typical finding of diffuse increase in skin thickening and lymphedema here. Fat necrosis can evolve in a very typical fashion, and this just shows sequential mammograms on a patient who's had a wide local excision. We have an oil cyst here, and here we see development of typical dystrophic calcification in association with maturation of skin thickening and retraction. Now, this woman was actually quite symptomatic. Early on, she has a typical oil cyst, and later on, she's effectively got a ping-pong-sized chunk of calcium sitting in her upper outer quadrant, and she actually required repeated visits. At this stage, we managed to aspirate much of the oil cyst, but when it's calcified like that, it's actually quite challenging to aspirate, as you might imagine. Dystrophic calcification is extremely common, and as many as 30% of patients may develop dystrophic calcification a year post-operatively, and it can be quite confusing. So if it's typical fat necrosis calcification, fine, but when it's evolving, you may see subtle linear calcifications, as in this patient here, and they can look quite like malignant microcalcification that you'd expect with ductal carcinoma in situ. So the most helpful thing to do is go back, look at the pre-treat mammograms and assess whether or not the patient had microcalcification originally. Now, something that we're seeing much more of these days is lipofilling. And this is the technique of harvesting the patient's own fat, centrifuging it to get rid of all the oil so that you're left with a collection of adipocytes, which is then effectively transplanted into the breast, into areas where the cosmetic result is not great. So typically it's used to improve defects after surgery or reconstruction. You won't be surprised to hear that fat necrosis and the development of oil cysts is extremely common in this situation, but the results can be quite dramatic. So here is a patient who had not a great cosmetic result. You can see the dystrophic calcification, the scarring and retraction at the site of the car, and post-lipofilling, she's really had a very good result indeed, and it may need to be done on repeated occasions. So how do we differentiate normal post-surgical change from recurrence? Well, firstly, there are the typical imaging features. The time course of the changes is also extremely helpful. Though the edema and skin thickening after radiotherapy may persist, it typically stabilizes by about 2 to 3 years post-treatment, and that's fortuitous because local recurrences tend to develop after that time, though it is also fair to say that radiotherapy can delay resolution of the post-surgical changes. And this graph here just makes that point rather better. So what we have here is time post-operatively. You can see that with time, fluid collections, skin thickening, and edema gradually diminish, whereas, unsurprisingly, calcification, scarring, and fibrosis gradually increase in frequency. Scars typically have central lucencies contained within them. They often look different on the different projections on a mammogram, which is helpful. And if after 2 or 3 years you develop increasing density, you need to be a bit concerned about recurrence. The sensitivity of mammography for recurrence is quite variable. It depends on how dense the breasts are. But MRI, particularly if done well after the radiotherapy effects have died down, can be extremely helpful. And this was a patient who actually was having an MR because, much to everyone's surprise, she turned out to have invasive disease. We thought we were treating DCIS, which was quite extensive, but her sentinel node was positive. So the surgeons wanted to know whether anything was left behind, and that was why the MR was done. And here you see a seroma in the axilla, and lots of post-operative changes here. Notice on the T2 weighted image, something that looks like it might be a hemosiderin ring, susceptibility artifact from clips. But on the T1 weighted gradient echo images obtained before and after gadolinium, you can see that actually there is suppression of signal in that central cystic lucency, and that was an oil cyst, later confirmed on the ultrasound, as you see below. Let me share a case with you. This was a woman whose operation was in 2010. Her mammograms from 2012 had stabilized with the scarring here in the upper outer quadrant. And a year later at her surveillance mammogram, she has a new lump here and another one here, this one containing a fleck of calcification. So we got very excited about this and we did a biopsy and it came back fat necrosis. It did look quite worrying on the ultrasound, as you see. The masses are not very well defined, they're hypoechoic, there's diminished through transmission, and they are very stiff on shear wave elastography. So it was all quite worrying, and we were a bit surprised by fat necrosis. So we went on to do an MRI, and this is the MRI scan. What you have are subtracted images here, post-intravenous gadolinium. You can see these two lesions looking somewhat spiculate, with little central signal voids, which should have given us a clue in retrospect, and washout curves. So that can actually look quite worrying. But we went back and did another vacuum-assisted biopsy, and it was all just fat necrosis, at which point we said, right, no more needles, we're just making the fat necrosis work, we're going to leave her alone, and she's now fine. I want to say a bit about reconstructions. These are becoming increasingly common, and they have very variable imaging appearances. The most commonly used these days are the autologous myocutaneous flaps, but you still have patients having implant-space reconstructions, or you may have a combination of the two. It really depends on the patient population that you're dealing with. And if your patient population is like mine, there are a lot of smokers who are substantially overweight, and so something that needs microsurgery for vascular anastomosis is not necessarily a good idea. This is a schema of the common myocutaneous flaps. There are 3 ones that are used commonly: the pedicle TRAM incisions, in which the whole of the rectus abdominis muscle is taken; the muscle-sparing free TRAM incisions, where an entire flap is not mobilized, but a little bit of muscle tissue is taken, as you see here, along with the deep inferior epigastric perforators; and finally, the increasingly popular DIEP flap. I would say most of our reconstructions were DIEP flaps now. And the great thing about those is you don't take the muscle. You take the subcutaneous fat, overlying the rectus abdominis, along with the deep inferior epigastric perforators. And this is what a pedicled TRAM flap looks like, with the whole thing being swung up. So you get a result something like that. Whereas with a DIEP flap, the subcutaneous fat is taken and the vessels are anastomosed, usually to the internal mammary vessels there, and you get a result like that. And coincidentally, a very nice tummy tuck. So with my population, that's extremely popular. Latissimus dorsi flats are still used quite commonly, in which the latissimus dorsi muscle is mobilized and taken with the skin and subcutaneous fat and brought around. Usually requires an implant deep to it as well. It's a popular operation because there's relatively low morbidity aside from dorsal hematomas and seromas. But if you're somebody like a golfer, for example, who is using that muscle quite a lot, it's obviously not a good idea. What you tend to see with the pedicled TRAM flats is that the muscle atrophies with time to leave predominantly fat attenuation. And a key thing to recognize is a thin, soft tissue band just deep to the skin, which represents the de-epithelialized skin underneath the flap, and then you have fat from the abdominal wall. And that de-epithelialized skin should be nice and thin about a month after surgery. One thing about TRAM flaps, obviously, is if you're removing the muscle, you can develop incisional hernias and abdominal muscle weakness. This is a patient who's had a DIEP flap. And as we go down, you can see predominantly fat attenuation. This here and here represents the contact line, and you can also see a little bit of scarring at the back of the breast and toward the axilla. Fat necrosis, unsurprisingly, very common, particularly with TRAM flaps. It's a clinical presentation. We personally do not do mammograms on the reconstructed breast. Hematomas, seromas, donor site complications, less common with the DIEPs, which is one of the reasons why they're favoured. If you're going to get vascular compromise with your microsurgical anastomosis, tends to happen early on during the operation, and usually it's venous rather than arterial, and of course occasionally there is the problem of tumour recurrence. Now this was a patient, this is not from my practice, we don't normally do PET scans to follow up patients who've had reconstructions, but this woman was symptomatic 16 months after bilateral TRAM flaps, and she did have a PET scan for reasons that are not entirely clear, but you can see there's a lot of soft tissue attenuation here, as well as fat density, and it is FDG avid, and it is well recognized that fat necrosis is a cause of increased FDG uptake. This particular patient went on to have an MRI, and you can see the oil cysts here with typical rim enhancement surrounding them, and that should get better with time. Now, if you develop recurrent disease, usually it's at the superficial contact line, so you can feel it. But of course, it can be deeper, and that is one of the downsides of the flat, that you may not be able to feel a recurrence that quickly. And you see a typical one just there, anterior to the chest wall, and probably involving the pectoral muscle. I'm not going to say too much about implants, but obviously, as with cosmetic implants, you may get complications. Early on, periprosthetic infection is the one that we worry about. Capsular contraction is a clinical diagnosis and does not need imaging. Rupture can be intracapsular, where the silicone envelope of the implant ruptures, but it's contained by the host, whereas extracapsular ruptures go out with the host fibrous envelope. A novel entity that's been described in the past few years is the so-called implant-associated anaplastic T-cell lymphoma. It is vanishingly rare, but I have seen one case, and I'll show you that later on. Now, the first line investigation in our practice is ultrasound, and if you can make a firm and confident diagnosis on ultrasound, that is fine, but otherwise you may need to go on to MRI. Now, a few pitfalls on ultrasound. It is normal to see a certain amount of pericapsular fluid at both ultrasound and MRI, but if you've got large amounts around the implant, especially early on, you may want to worry about hematoma or infection. And here is one such example in a patient who's had bilateral recons. Notice the contact line and then implants deep to it with large amounts of fluid around the implant. So clearly, correlation with the clinical history is essential. This is another pitfall that we fall into all the time, and there are very good reasons, specifically that the surgeons very, very rarely tell us what sort of implant they have put into the patient. So this patient had an ultrasound, and this looks for all the world like a stepladder sign, which you see with intracapsular rupture, and yet when you look at the MRI, it is clear that what we're seeing is a double lumen implant. So here you have saline and silicone components, and there's another single lumen implant on this side for symmetrization. The double lumen implants can be very complicated to sort out. The one that's most commonly used is a Becker implant, and that has an inner saline component that can be expanded gradually to increase the size of the breast to the desired shape and size. And so using a combination of sagittal and axial T1, T2 rated stir and silicone selective sequences, you can usually sort out exactly what is going on. And there you see the actual tubing that is used to expand the saline component. Beware though, if somebody has had a Becker implant put in very early on, it can look concerning for infection. And here you see a patient who has had just that, and you can see there's lots of air, a bit of peri-implant fluid at multiple levels, and probably best appreciated there you see the port through which the implant is expanded, and there is the tubing. So this is totally normal post-operative appearance. Now, this is the one instance that I have of a T-cell anaplastic lymphoma. The common presentation of these lesions is late development of a subcapsular seroma, which is exactly what you're seeing there. And there it is on the axial water-suppressed image and the gradient echo image with fat suppression. Usually, actually, if you just remove the implant, it settles down, and surprisingly, they don't need much in the way of systemic treatment. Now, I've talked about radiotherapy in relation to the breast, but I want to say a little bit about its impact on the surrounding structures, specifically the lungs and the bones. Within the lungs, you may see smooth pleural thickening within the radiation portal. The radiation pneumonitis usually develops sometime after the treatment has been given, and whether or not you develop it depends on the dose, the fractionation, the portal, and the volume of lung irradiated. Now, at the stage when there's a latent pneumonitis, we don't see very much on imaging, but in the intermediate phase, when there's an acute exudative pneumonitis, we typically see ground glass or airspace opacity, which later on evolves to fibrosis, which can progress for up to 2 years. And the typical manifestations on CT, you're well familiar with: scarring, volume loss, traction bronchiectasis. And the location is obviously going to depend on the fields that were applied to the patient. So this patient had tangential fields applied to her DIEP reconstruction, and here you see quite dense consolidation and airspace opacity. The pleural effusions were actually incidental. She also had factor V Leiden deficiency and had multiple pulmonary emboli. Here is a paramediastinal field, and here is what you tend to see with supraclavicular irradiation. And in a patient who's had a mastectomy, that should lead you confidently to diagnose the etiology of the subpleural fibrosis that you see here. Unfortunately, there are 1 or 2 other rare sequelae that need to be mentioned, specifically the development of secondary radiation-induced sarcomas, and these are mercifully rare because they're horrible. The cumulative incidence is very low at 10 years, and they tend to be seen after a latency of about 5 years, and this is the typical appearance of a secondary angiosarcoma. and it's really a desperate situation, but it may develop in a breast that's been treated with wide local excision, and in this scenario, the MRI can help by showing the plastic surgeons the depth of penetration into the chest. Bone changes we do occasionally see. Insufficiency fractures tend to be relatively painless, and on the bone scan, the clue lies in the rather sort of geographic nature of the increased tracer uptake that you see here. But you actually can go on and develop frank osteoradionecrosis of the ribs as well. Because of all the complications of whole breast irradiation, there has been a move towards accelerated partial breast irradiation, APBI. And this can be done in a variety of ways. It can be done intraoperatively, or using balloon brachytherapy, it can be done over about a week with twice daily treatments through catheters that are inserted into the tumour bed. In terms of oncological safety, they have been shown to be safe, with little difference in the 12-year recurrence rates or the overall survival, but as you would expect, with better cosmesis and less toxicity to the surrounding tissues. However, again, not altogether unsurprisingly, palpable lumps post-brachytherapy treatment are not uncommon, particularly seromas, focal distortion, focal fat necrosis, and scarring. And there's been a recognized markedly increased incidence of seromas. On the other hand, you get less pulmonary fibrosis. So this just illustrates the difference between somebody who has had whole breast irradiation and somebody who has had IORT, and you can really barely tell that this patient has had radiotherapy at all. Again, you see the typical changes over time with fat necrosis and dystrophic calcifications, but at least it's limited just to that area of the breast. Another problem that unfortunately we still see is delayed onset arm lymphedema, which is a complication of the axillary surgery, may affect up to 1/5 of patients who've had a lymph node dissection, and if you've had radiotherapy as well, you're almost bound to get it. Radiotherapy alone can cause a delayed radiation fibrosis, and the differential diagnosis is obviously recurrence. This was a patient who I saw last week who developed delayed onset lymphedema. There was absolutely no evidence of recurrent disease, and you can see a pristine brachial plexus. Unfortunately, she did have lots of unsuspected liver metastases. So just quickly, I want to say a little bit about brachial plexopathies. With modern conformal radiotherapy and CT planning, these are mercifully much rarer. They tend to produce predominantly sensory symptoms early on before progressing to muscle weakness and atrophy. High doses, big fractions, overlapping fields all make you more likely to get it. And unfortunately, it's usually irreversible, whether it be acute or delayed. And the MR findings are usually pretty characteristic. Loss of clarity on T1 weighted imaging, thickening of the chords and divisions, loss of the fat planes, hyperintensity on T2 weighting or stir images around the components of the plexus. You may see enhancement, and with chronic changes, you go on to get massive thickening. What's helpful in sorting out that from recurrence is the presence or absence of eccentric masses. And of course, you may see other signs either of radiotherapy or of metastatic disease. And here's one such patient. It does look a bit like a dog's dinner, but you can see that there is gross thickening here on the T1 weighted images, and that's just shot ahead, I apologize. But you can see it again here with high signal on the stir and radiation changes in the apex of the lung as well, and really substantial thickening on the sagittal T1 weighted images around the component of the plexus, and an even more dramatic appearance here on the right-hand side with gross thickening, no sign of recurrence, and that's a devastating condition because there's nothing you can do about it. Chemotherapy, final few sentences now. The major treatment for breast cancer in most places is a combination of FEC, 5-fluorouracil, epirubicin, cyclophosphamide, with or without a taxane, usually docetaxel. And both of these components can cause a pneumonitis. Trastuzumab, targeted therapy for HER2 amplified cancers. The cardiotoxicity is the main problem that we have there, and of course that may be manifest on CT or ultrasounds. And just final sentence here, a little word about targeted therapies. This is the PAM pathway, the PI3 kinase AK kinase and the mTOR pathway, it's completely dysregulated in ER-positive breast cancer often, and is thought to explain a lot of resistance to endocrine therapy, such as with an aromatase inhibitor. So a new drug on the scene is the mTOR inhibitor everolimus. And that's been shown to improve progression-free survival, but it has a nasty habit of inducing an interstitial pneumonitis, which can be global, as in that patient, or rather more focal, usually mild and self-limiting, but can be very serious indeed. So it's just something to be aware of and to ask your clinicians when you're faced with a scan that looks like that. So just in conclusion, I hope that I've talked you through some of the acute and chronic effects that we see in the locoregional treatment of breast cancer, generally predictable with a predictable evolution, which helps us as radiologists sort out what is going on and to be able to reassure our patients and clinicians appropriately. But with the effect of ever-changing treatment, we just do need to bear in mind how many of these novel treatments do have specific imaging features that we need to be aware of. Thank you very much.